Good evening, everyone. Before we move on to the inaugural function, we have one more session, which is Cutting Edge Conclave Best of EULAR 2022. And to chair the session, I would like to invite on stage Dr. B.G. Dharmanand, who is Consultant Rheumatologist at Vikram Hospital, Bangalore, and Dr. Shwetal Pandey, who is Consultant Rheumatologist in Department of Rheumatology at Max Super Specialty Hospital, Saket, Delhi. This session will be followed by inaugural function and a magnificent dance performance by world famous Kathak dancer Ragini Makad. So you don't want to miss that one. So let's begin this session and let's try to finish in time.
Yes. Good evening. For this session, I would like to invite our first speaker, Dr. Daniel. He's a chair of rheumatology, head of division of rheumatology in Medical University of Vienna, Austria.
Thank you for inviting me and having me. And maybe my topic is a little bit dry. It's about how does EULAR develop guidance. And I think, though, that maybe some of you may think when they see products or documents coming out of EULAR saying recommendation for this or points to consider on that or criteria for this or that, sometimes you wonder what's the process behind it. And maybe I'm not only talking about methodology, which can become very, very dry, but about the whole process, how EULAR makes a decision about what to address, where to provide guidance documents. And I thought I give you an idea of that in the next couple of minutes. First of all, EULAR has old SOPs that were published, and EULAR stopped now from publishing them because the SOPs are also changing, and now we have them as living documents on the website. So any one of you who's really interested can review the EULAR SOPs of developing guidelines at eular.org, and the quality of care. It is easily accessible, a PDF that shows all the details of what I'm trying to tell you now in a few minutes. Now, let me start with terminology. And when EULAR, ACR, or other societies produce documents meant for clinical practice, guidance documents, they have different terminology. And I just want to briefly remind ourselves what the different terms mean. Guidance, and the ACR uses the term guidance, I don't know if you've noted, as a term, and guidance is really really weak. The term guidance, it's an advice or a counseling on some topic, but not really much more than that. The next levels are points to consider. To consider is already implying that it's a little bit stronger, but it's still based on weak evidence. So when EULAR products are out, and you will sometimes wonder, why is something called points to consider, and why is something called recommendation? It's not two different things, it's just a spectrum. So points to consider you will find for rare disease, for diseases where there's not sufficient evidence to create a lot of evidence-based guidance. So when you have diseases like RA or psoriatic arthritis or axial spondyloarthritis, where there's lots of studies, lots of clinical trials supporting the recommendations, then you can call it recommendations, and that's what you will see, and that's the basic difference of these two. Guidelines are rarely seen. I think there is some guidelines out, but guidelines are very strong. Guidelines have legal implications often in some countries. So definitely EULAR, but also I think ACR have moved away from producing guideline documents that imply that somehow if you don't adhere to that guideline, you're not conducting good clinical practice, and in some countries that may lead to legal issues. And there's even rules. And we could say, well, we don't have guidelines, we certainly don't have rules. Well, we do have some rules too in our medical practice, and it's the code of ethics, for example, or the code of conduct. We also swear an oath when we become doctors. This is something like we swear to a rule, and so we are practicing rules as well. So when we talk about EULAR products, usually you find points to consider and recommendations. And you can have even a document points to consider, final note on this slide, if you don't have any studies, because then a consensus of experts is the best evidence you have. If there is no evidence, then at least you have a consensus of experts. So we have to understand that it's the lowest level of evidence, but it's still the best evidence if you don't have any other evidence. Of course, we would like to have randomized controlled trials for each clinical question, but that's rarely the case. Now, who can develop guidance documents? And I call all of these guidance documents now because I didn't have a better term in the name of EULAR. It can come from the community. EULAR lets the community propose in a spontaneous manner these topics. And any member of EULAR, any member of a EULAR society can propose it. And this person is then a convener of this. And you can see when you go to the EULAR website, a lot has happened in the last 2 decades or so. More than 40 classification projects and more than 60 management recommendations / points to consider. So a large number of guidance documents, some outdated and updated, and depending on the dynamics in the respective field, of course. So how do we in EULAR then decide on topics? So if everyone out of the community can propose something, you can imagine that is the most important issue, how to decide what is important. Because if you are a person working on a very specific field, that might be the interest of your life. You will propose this, but it may not be relevant to a larger community. So EULAR needs to find some formal and objective ways to decide which topics are relevant. And I think if the output needs to be useful, then a few things need to be in order. First, you need to have a relevant project that is important. Then you have to have a right team, people who are working in the field, who are clinical experts, also scientific experts, but at least a good mix. You have to have the right methodology, which is the technical part, and I won't go into that for obvious reasons, because it's not something that is necessary for a broader community. And also, and that often is forgotten, across the world for all the guidance documents, that it's really about implementation. And implementation is where we all fail, usually. We produce documents, we have nice and shiny papers, but when it comes to, clinical practice and how these documents change clinical practice, we have a lot to improve. So the relevance EULAR really follows a new process now that is really about, after the topic submission, there is a pre-eligibility check in the EULAR Council of whether this topic is important. So council members of EULAR rate on a numerical rating scale how important that topic is to the community, even without knowing who the author is, so there can't be personal issues. They are provided a list of previous projects in the same area, so they know the relevance and timeliness. If there's nothing, it may be more relevant. If there's 3 years ago a similar project, then it's less relevant. And then once it's considered eligible, the quality of care committee supports the person, not works against the person, but supports the person to propose an optimal proposal, to develop an optimal proposal that can then be decided on. So this is the process of selection. And then one word about the team. The team that works on developing these criteria is often a mystery. Who are the people who are how are they selected? How do they work on? Well, I mentioned the convener. The convener is the one who brings the topic forward, but is actually scrutinized by the first step that I'm showing here about relevance. But then a EULAR task force is not one person, it's not only the convener. The convener has to bring on board a methodologist, someone experienced in evidence-based medicine, someone who knows how to guide systematic literature reviews and to extract information and to evaluate the quality of studies. If you don't have that, how can you discuss evidence? So this is very important, but the most important part, of course, is the person who is doing it, the review, because that's a lot of work, and some of the EULAR projects have even 3 fellows doing the work. The fellows are the only ones, by the way, who get a financial compensation for the work, because it's a lot of work to conduct several systematic literature reviews. We always have patients on board. The patient's representation in EULAR has a long history, and we have young rheumatologists on board. EMUNET is the association of the young rheumatologists within EULAR, and we also try to have fixed 2 members of EMUNET as young members on board, a healthcare professional, and then we are, as EULAR, also convinced that we need to have a better geographic representation of our member states, so we open 5 positions for active application from EULAR member states to propose people who can be on the various task forces, and that's an open call, and people can, it's not a closed club, that task force. It is open to any community member that is interested and is sending in a CV. And then the convener has the right to identify additional experts, and I think that's also important. So this is how the team is composed, and the team will eventually make also the difference. The methodology is as simple as it's shown here, really from scoping existing data, formulating the guide, the questions for a literature search, step 2, step 3, then getting and summarizing the evidence and extracting it, and then in the last step, really formulating recommendations as a group. So you are presented the data from the literature. In the first meeting, you decide what to search. In the second meeting, you see the data, and then you formulate tentative bullet points for recommendations. And then it's an open discussion about how to formulate these based on the evidence. And as I said before, sometimes if one or the other question doesn't have an answer, you get the best possible clinical consensus. Anything is better than having no data. And this is, so to say, that the formal process in EULAR, from planning a meeting to the systematic literature review, the consensus meeting, and then the EULAR Council reviews what's coming out, and the main publications is what you usually see. So this was a brief journey across the different steps, and I'm not going into the methodology I promised. We are using the Oxford level of evidence in EULAR, so you will find for every recommendation in EULAR, you will find a category of evidence and the strengths of recommendation derived from it, and you will find a level of agreement of the committee members with each statement that gives you a sense of how concordant the view is or how much debate there was. From 0 to 10, usually you find something 9.7, 9.8 if you have good consensus on an item. But sometimes you find items that are 7.5, and then you know there was a large discrepancy or disconnect between people. This is just how it looks in the tables when you review them. This is the 2019 EULAR recommendations for RA. The rightmost column, you can see the level of agreement, and you can see it's usually above 9. Anything below 9 should actually raise our interest and at least tells us that there is some disconnect. Finally, the implementation. The last word, and I made it in the beginning and I want to come back to it, nothing is useful if it doesn't get to the consumer, and EULAR is investing a lot in advocacy and implementation, communication to its members, but also outside its members, and I think that's the biggest area that can be improved in the recommendation setting. Everything else is formalized, but the implementation is yet to be optimized to really bring the recommendations to the community. So in summary, we try to have an unbiased attitude towards selection new proposals. So we give a very open possibility to everyone to propose, but then try to objectify the relevance as a committee. We have, I think, quite a reasonable approach of putting a team together. We need some experts. You need to give the convener the right to select people. It's not a private club if the convener selects 3 or 4 of his or her friends who work in the same field, because we need the experts and we need the convener as one of the experts to identify other experts. But at the same time, we're opening up for member states, for patients, young rheumatologists, healthcare professionals, etc. EULAR scrutinizes its output and then decides on where it is published. Usually it's the Annals of Rheumatic Diseases or RMD Open. And as I said, and that's my final point, implementation is really something that we as EULAR will work and invest on in the future very intensively. Thank you very much for your attention.
Thank you so much, Dr. Daniel, for a wonderful talk. And it was really interesting to understand and know how EULAR guidelines are made and which we read and follow. So now I would like to invite our next speaker, Dr. Shashank Akrekar, who is consultant rheumatologist at Mumbai Arthritis Clinic and Research Center in Mumbai.
Good evening, everybody. I'm pleased to present the proceedings from EULAR2022. Given the time constraints, I would basically restrict myself to newer molecules, newer pathways, and the relevant data presented at the EULAR. Let us start with spondyloarthritis. As we all know, enthesitis is a cardinal feature of spondyloarthritis, and there is a dearth of data, particularly cellular level data, when it comes to JAK inhibition in enthesitis. Guys et al. Came up with their details of their study, upadacitinib effect on innate and adaptive immune responses in an in vitro human enthesis model. Normal spinal process enthesis were isolated from patients undergoing spinal surgery for degenerative spine disease and scoliosis. Enthesized cells were isolated and they were then stimulated with interferon gamma with or without upadacitinib, and STAT1 activation measured. Upadacitinib inhibited phosphorylation of STAT1 in enthesial cells following the interferon gamma stimulation. Enthesial T cells were stimulated with anti-CD3 with interleukin 23, and anti-CD3 with interleukin 1 beta with or without upadacitinib. And following this stimulation, enthesial T cell upadacitinib inhibited both TNF alpha as well as interleukin 7 production. So this gives us a mechanistic explanation as to how JAK inhibition works in enthesitis at the cellular level. A lot of data about upadacitinib was presented at the EULAR2022. Devdar et al. Came up with the Select Access 2 data. Select Access 2 has a master protocol with 2 independent studies in 2 different populations of upadacitinib. The first study, upadacitinib in non-radiographic expa. Again, there is dearth of data when it comes to JAK inhibition in non-radiographic expa. There is a lot of data and it has been approved for ankylosing spondylitis. So this study looked at the non-radiographic expa population. It was a randomized double-blind placebo-controlled phase 3 trials. Adult patients with active non-radiographic expa randomized to upadacitinib 15 mg once daily or placebo with the primary endpoint of ASAS 40 at week 14. And as you can see, the response rate for upadacitinib was almost twice as compared to placebo, 45% versus 23. There was a significant response in the clinical parameters, and also MRI detected SI joint inflammation as against placebo in this study. Coming to the second independent study of Select Access 2, upadacitinib in ankylosing spondylitis refractory to biologics. Again, the population, adult patients, active angspond, and either intolerance or inadequate response to one or two biologic DMARDs, either TNF-alpha or interleukin-17. Same primary endpoint, ASAS-40 response at week 14. And again here also, there was significantly more patients who achieved the primary endpoint of ASAS-40, 45% versus 18%, showing that upadacitinib is quite effective in this population as well. No new side effect profile was seen in this. Serious infections occurred with upadacitinib but not with placebo and included 4 events of COVID-19 and 1 event of uveitis. So no new safety signals in this. There have been quite a few studies looking at the role of NSAIDs in retarding the progression of the radiographic progression in axSpA. So this study looked at celecoxib plus golimumab as against golimumab alone, whether there is any additional benefit of retarding the radiographic progression. It was a 2-phase study, 12-week run-in phase with golimumab every month, and if the BASDA improvement was more than 2 points, then these patients were randomly allotted to either golimumab plus celecoxib or celecoxib alone. Combined therapy did not show significant superiority over golimumab monotherapy in retarding radiographic progression. However, there was a numerical reduction in radiographic spinal progression, which could suggest that if patient has a high risk of progression, NSAID, continuous NSAID therapy might be added to anti-TNF therapy. Moving ahead with the same radiographic progression, PROOF study, which was a global real-world prospective observational study conducted in rheumatological clinical practice in 29 countries, looking at the radiographic progression from non-radiographic axSpA to radiographic axSpA. 16% of non-radiographic axSpA patient progressed to radiographic axSpA in 5 years. Mean time to disease progression was 2.5 years. And predictors of radiographic progression were mainly male gender, good response to NSAIDs, fulfillment of the imaging arm, as well as HLA-B27 positivity. How about lupus? A lot of data about TYK inhibition in lupus was presented in this EULAR. Deucravacitinib is an oral TYK2 inhibitor, and TYK2 mediates signaling of type 1 interferons, interleukin-23 and interleukin-12. This is already approved for plaque psoriasis by US FDA. This was one of the earliest studies as far as lupus is concerned. Adult patients, active lupus, randomized to 3 different doses of deucravacitinib versus placebo, 3 mg BID, 6 mg BID and 12 mg BID. And the primary endpoint was the proportion of patients achieving SRI-4 at week 32. As you can see, the most optimal response was seen in the deucravacitinib 3 mg BID dose. Almost 58.2% patients achieving SRI-4 as against 34.4 of the placebo. This was sustained at week 48 as well, and most of the secondary criteria were also met. There was no new safety signal, and the most common side effects were respiratory tract infections, nasopharyngitis, headache and urinary tract infection. One more pathway that being looked at in a new molecule, orelabrutinib, which is a Bruton's tyrosine kinase inhibitor, phase 1b/2a randomized double-blind placebo-controlled dose-finding study aimed to evaluate safety, tolerability, pharmacokinetics and dynamics of orelabrutinib in lupus, was presented at the EULAR. This again had patients with active lupus who were randomized to orelabrutinib 50 mg, 80 mg, 100 mg or placebo for 12 weeks, and the results for the various doses were all significant. 50% with 50 mg, 61.5% for 80 mg and 64.3% with 100 mg as against 35.7% with the placebo, meeting the primary endpoint. Again, in this also, there were no new safety signals that were observed. Coming to the newer developments in gout, there hasn't been much of data about JAK inhibition in gout. This was one of the first studies looking at JAK inhibition in gout, looked at the levels of 4 JAKs and 7 STATs in peripheral blood mononuclear cells of 100 gout patients versus healthy controls, and these levels were found to be on the higher side. A rat ankle model of gout inflammation Again, JAK3 and STAT5 phosphorylation levels in synovial tissues were increased, and this phosphorylation of JAK3, STAT5, interleukin-1 beta and interleukin-2 was significantly reduced with colchicine treatment. So again, this was one of the first studies looking at JAK inhibition and whether there is any role of JAK in gout. A good real-world data of gout was also presented. This was a 5-year trajectory of urate lowering therapy and impact of colchicine on cardiovascular risk. 70,000 plus patients, LRX database, which is a French pharmacy database. And what was seen, these patients were tracked for almost under 1 year. What was found in this was something that we already know. One, urate lowering therapy compliance is poor, with almost half of the patient discontinuing treatment under 1 year. The second most important, the study also demonstrated a reduction in cardiovascular treatment in patients on colchicine prophylactic therapy. So this obviously needs further data and further trials, but there could be a cardioprotective effect of colchicine therapy as per the data that we have. A lot of data looking at JAK inhibitors, MACE and VTs was presented in the EULAR. This was a data from the WHO database between Jan 2011 and end of 2020. Patients with a diagnosis of RA between age 18 and 75 on JAK inhibitors and anti-TNFs were included, and MACE including MI, stroke, cardiovascular events and venous thromboembolic events were looked at. The analysis did not identify an increase in declaration of MACE with JAK inhibitors, but there was a definite 3 times higher in declaration of VT in this database as far as JAK inhibitors was compared against anti-TNF. Biomarkers were looked into to whether there is any biomarker that can predict MACE or VT in JAK inhibitor therapy, but no biomarker was found to be significantly associated. And lastly, a JAKpot study which looked at tolerance and safety of JAK inhibitors vis-a-vis other biologics, and after adjusting for the potential confounders, the rate of treatment discontinuation for adverse events was comparable between JAK inhibitors and TNF-alpha inhibitors and the other biologic DMARDs. We have always seen that the effect of JAK happens early, and probably it is more than the amount of reduction in the inflammation in rheumatoid arthritis. This is something that was again looked into. JAK inhibitors and central sensitization. 115 patients scored their pain catastrophizing scale and central sensitization inventory, and what was found that SDI achieved almost 10.6% remission and 15.2% low disease activity, and the changes in SDI were exclusively connected to changes in catastrophizing. So the JAK inhibitors does have a role in central sensitization reduction as well, and that's also the reason possibly why we see the reduction in pain more than the reduction of inflammation that we see in the patients. A lot of data of other biologics in psoriatic arthritis as well, bimekizumab data. It is a monoclonal antibody that blocks interleukin-17F in addition to interleukin-17A. Patients with active PSA and biologic naive. This study had a reference arm of adalimumab and 2 arms wherein initial phase it was only placebo, 16 weeks only placebo, which moved on to bimekizumab, and the other group continuously on bimekizumab, again showing significant effect with respect to bimekizumab over placebo. This was not supposed to be a comparative study between adalimumab and bimekizumab, but as you can see, apart from the ACR 50 wherein the two are comparable, PASI 90 definitely bimekizumab has a much higher response rate as compared to adalimumab. Same bimekizumab was also tested in a different population group, patients of psoriatic arthritis who were refractory to other TNF blockers. A similar sort of a data here as well, significant response of bimekizumab against placebo, and the effect of bimekizumab was visible as early as 4 weeks. One more new molecule, risankizumab in psoriatic arthritis, the keepsake 1 study showing significant effect of risankizumab. Risankizumab is a monoclonal antibody that specifically inhibits the P19 subunit of interleukin-23. Significant effect at week 24, 55.3% versus 32.9%, and PASI 90, 52.7% versus 9.9%. One of the molecules that we have already seen that was tried in lupus, deucravacitinib in psoriatic arthritis. Not a very promising result in this. Active psoriatic arthritis patients, deucravacitinib versus placebo, most of them had numerically significant improvement in most of the domains of MDA. Lastly, we are always afraid of starting TOFA or JAK inhibitors or biologics in patients who already have a history of malignancy. So this was one of the study who looked at patients with a prior malignancy from BioBasdar registry when these were started on JAK inhibitors or TNF-alpha inhibitors, and the overall incident malignancy events were 27.1 per 1,000 patient years. The overall rate of incident cancer did not really differ significantly in patients exposed to JAK inhibitors or anti-CD20, anti-IL-6 or anti-CTLA4 as against TNF-alpha therapy. Lastly, we can't end the session without our own data coming from our very own Dr. Shenoy. So COVID-19 vaccine and methotrexate withdrawal, MyVac-1, where unvaccinated patients were randomized to either hold or continue methotrexate 2 weeks after each dose of the vaccine, and MyVac-2, which included patients who had continued methotrexate during the first dose and were randomized to hold or continue methotrexate for 2 weeks after the second vaccine dose. MyVac-1, the anti-RBD titers was significantly high in the methotrexate hold group, but the flare rate was also high in the hold group. MyVac-2, the anti-RBD titers was significantly high for the methotrexate hold group but when compared to the control group, but there was no difference in the flare rate between the two groups. So holding methotrexate after both the doses or only after the second dose yields higher anti-RBD antibody titers as compared to continuing methotrexate. Comparing across the trials, holding methotrexate only after the second dose appears to be non-inferior to holding methotrexate after both doses of the vaccine with a little risk of flare. Thank you.
Thank you so much, Dr. Shashank. It was really enlightening to know the newer molecules which are coming in rheumatic diseases. So now I would like to open the session for any questions to the speakers. So if there are no questions, so we should close the session. Okay, thank you.